All right. Hello, everybody. So nice to see you. Enjoy your lunch. But we're going to get going here. I'm Lisa Suennen. I am the proud owner of this megaphone, so do not screw with me. Thank you very much, Rob and Jen. That's very sweet. Delighted to be here today. I am today starting a new job, very excited, at Manatt Phelps with a couple of my colleagues over here. Yay! And so this is my first official viewing in this role, and I'm really excited to be here. I have some amazing people to my left who will be talking with lettuce in their teeth probably, but that's okay. I'm going to let each of them introduce themselves in a moment, but I want to encourage you, while I've got your attention, to please check out Manatt, but also to check out C Sweetener, which is a not-for-profit that I started to help women executives in healthcare find mentors and speaking opportunities and to step up in the space. So you can find that at csweetener.org. But without further ado, perhaps you could introduce yourself.
Happy to. Sharon Vitti, Senior Vice President at CVS Health, and I run Minute Clinic.
Right.
I'm Iyah Romm. I'm one of the founders and the CEO of City Block Health.
Why did I take a bite? Sorry. Go next. I'll go.
Okay, I am Tony Boselli, the president of CareDocs, and my partner and boss is the CEO of Heskey's right over there. So I got to make sure I say the right things, so I don't get in trouble.
Yeah.
I can believe I'm his boss.
Awesome. Thank you guys.
Very gallant. And I'm Jenni Vargas. I'm the Chief Strategy Officer at One Medical.
Excellent. So just want to start with, maybe I could get each of your perspective on what is primary care, because it's a word that I think has become sort of, buzzword bingoized a little bit, and I'm wondering how you define it for yourselves and for your organization. So why don't we start with you?
So in thinking about this, I think primary care is evolving similarly to how the ambulatory care continuum has evolved. So when you think back 10 years ago, in the ambulatory care, there was your primary care provider and the emergency room, and there wasn't anything in the middle. And now there are several options in the middle that make sense for patients, depending on what they need and where they are. And I think primary care is similar. I think primary care has this generic title, and I think that as we start listening to and looking out in the landscape, there are different primary care offerings for different populations to meet different needs. And I think that's where we're going with primary care. So I think the label of primary care is tough. I think how we define what primary care is for which populations, and we have to name it accordingly, and I think that's the work. How do we name primary care, the level of the offering?
Thanks. Iyah?
It's a good question, Lisa. You had to start there. So it's really, for us, primary care depends on context. So we don't consider ourselves delivering primary care, frankly. When you think about the notion of primary care, I think when we talk to health plans, primary care means a way of paying for certain services. It means a way of assigning an individual, a beneficiary, to a certain doctor in certain insurance products, and all that's fairly meaningless to our model of care. So we speak that language in certain contexts in how we contract and how we think about the financing of our model. But when we talk to our members, we talk about whatever matters to them. And so we serve predominantly a Medicaid and dually eligible population at City Block. And what it means is that whatever matters to them matters to us. And so there's a set of services underneath primary care that are traditional preventative health, some level of urgent care, some diagnostics, some basic supportive services over time. We think that traditional behavioral health services have to be part of that sort of quote-unquote primary care offering as well. So all of our primary care docs, for example, in our model, who are trained that way, are required to be buprenorphine waivered to be able to do medication-assisted treatment for addiction, because it has to be a normative model of what it means to provide the basic level of services to a population. So it's a really interesting question for us, frankly, because I don't know that anybody knows what it means anymore, and so we're kind of moving away from it as a terminology, except from a business purpose in certain sets of conversations. It certainly doesn't matter to our population. Nobody assigns, and nobody describes their primary care provider. They might have that doc that they've seen for a long time, but they have no idea that they're a PCP or anything else, and I just don't think it matters that much.
All right.
Well, thank you. Well, I'm a recovering payer person, so sorry about that. But back in
no
the
recovery.
80s, when we defined managed care, you know, primary care was a gatekeeper. It was a bad thing. It was the person who told you couldn't have the specialist visit, that you just had to wait a little bit longer before you had an MRI, right? So I think we're really trying to move beyond that. And if you were to ask One Medical patients what primary care is, first they say, what are you talking about? Because they don't use that terminology, right? They'd say, it's the place I go with the really nice people who help me with my healthcare problems. And I do it in person and I do it virtually, and it's everything from, what do I do about this wart? To, I can't get my prescription from Optum Rx, to, I think I may have a heart condition. So I think when you think about it from the patient's perspective, which is, I'm only recently to One Medical, but I'm very impressed with what Tom Lee founded 11 years ago and his commitment to be really patient-centric. And we're trying to redefine the category, if you will, of primary care to be the trusted healthcare advisor to a family.
So when you talk about the PCP, the primary care provider, in pediatrics, it's your child's main pediatrician where you're going to go and get that basic preventative service when they're sick, and the main family member or the parents don't know what that means. I mean, they just know it's the doctor they go to when they have the ear infection, the sore throat, and it's different depending on the population you're talking about too. I think what Iyah said is very true. So if you look at the commercial population, and they go and they have their pediatrician that they go to, and it's the non-specialist that will tell them that their child, you know, how tall and much they weigh, and how where they get the prescription from when they don't feel good, and to get their school physical and the flu shot and all these different things. As you look at the Medicaid population, I think that's what we want to be. We want the PCB to be the medical home, to kind of be that quarterback to make sure we're driving care to where it needs to be, is kind of the front door of all healthcare. The problem is it's something that we want, but I don't think it's realistic a lot of times if you look at how the Medicaid population accesses care. And so at CareDocs, as we think about it, and as we look at it, of where these services, these preventative and care management services can be done and should be done, is where the population is. And so our whole goal is to create a platform to coordinate and enable care for every child, and to become, I don't think we want to compete with the medical home, but to be the hub where that we can make sure they're getting the proper care, and to be that front door. And we feel like leveraging schools and partnering with schools to do that is a very effective way.
So you guys, a couple of you brought up terms, the gatekeeper term that Jenny said, and the new front door. Those are, in a way, the same thing, I think, you know. And I have this theory, and it's particularly interesting since all four of your groups are not affiliated with hospitals directly. So disaggregated or, you know, disintermediated from the hospitals. So do you view it as your role or your ability to be not just the front door, but the off-ramp, so where they go, and to control where people go for services afterwards? Should the hospitals be scared of you? Anyone?
Well, in value-based care, we should be the hospital's best friend. If you're talking about true value-based care.
A hospital's best friend.
Or a hospital, thank you, a hospital's best friend. Because if the goal is to create better outcomes at a lower cost, and to make sure people are living healthy lives and getting the management and managing diseases like asthma, 11% of the population, pediatric population, has asthma, and urban population is much higher. It's one of the more preventable or treatable, to make sure it's managed properly with some basic education. And so as we look at it, is in value-based care, is you don't want them accessing the emergency room and that be their front door and driving up higher healthcare costs. And so partnering with us and partnering with where these individuals are to help drive down costs, better outcomes would be a natural partnership.
So,
in a fee-for-service world, probably not.
anybody else? Jenny, what about you? You guys are
Well,
kind of right in their face.
Well, at One Medical, patients expect us to enable their specialty care. So we've actually for years had curated lists. Our doctors will, in their each market, and we're in 8 markets going to 9, but they'll have a list of who's good, who's high value. Most importantly, who can you get in with? So if we're trying to refer to the super specialist, but you can't get an appointment for 6 weeks, that's not going to work. So I think we're very committed to only providing typically primary care services and not being the specialty business. So I think the disaggregation interest is all the money is on the specialty services, and primary care is generally underfunded. We'd probably all agree with that. My panelists would agree. Yes. So I think one of the tricks is that money is all at the surgeons and the hospital care, right? So it's not being provided to primary care. So we have to sort of manage that. That's a big opportunity, but we're not trying to do anything harmful to any part of the health system, including hospitals. Our patients typically use the emergency room at half the rate of a normal population. We use almost no urgent care because they have the app and they can just call us and have a video visit. So I don't think of it so much as disaggregating, it's just us being so committed to providing excellent primary care, which includes referring out.
But that reduces the
to
revenue
specialists.
of the hospital systems with, that would
It
normally.
can, but most hospitals would tell you, and I come from 10 years at an academic medical center at Stanford, where the emergency room was slammed. They don't want these patients. The people that don't
But
need
the
to be
urgent
there.
care centers are.
Urgent care center is different.
different.
Yeah. So that's a different business, and it's kind of like urgent care is the physical manifestation, and then there's the virtual. I mean, where does that all fit in? Our patients tend to want to come to us because they know our system. So if they're traveling, whatever, they can just do a video visit. If they have to because they need stitches, go in, of course, then they'll do that.
You want to say something there?
I mean, I think it depends on what horizon you're thinking about. If your question is the hospital CFO, should the hospital CFO be afraid of all of us over the next 5 years because of their fee-for-service base? I think the answer is absolutely. Like there is no question in my mind that if the 4 of our organizations are successful, we will drive revenue out of hospitals, period, full stop. And we have a hospital, we have to right size acute capacity in this country, and that's a really hard set of conversations that are for smarter people than me. I have gotten myself burned more than once trying to do things like bed buyback programs up in Massachusetts, which didn't go anywhere fast, but we're overbedded. I think the slightly longer question, I actually agree with some of what Jenni said. I think it also depends on which patient. So, our folks, most hospitals have no interest in having them in their beds because they lose money on a DRG and they lose money in the ED because you're talking about folks with complex behavioral health needs and who don't have anywhere to go on discharge, so they just get stuck in the hospital. Having a safe transition point back to an alternative care setting is potentially powerful. But I think it's pretty interesting. I mean, you look at, for example, the Ohio Health ChenMed partnership that just got announced recently, and without saying more, I'll say we get a lot of calls from health systems who recognize that in order to do something different, they need to find a way to build very different capacity. It is fundamentally about controlling the volume that they want, which is specialty volume, and being okay giving up a little bit of it.
Your turn.
Yeah. So I came out of academic medicine before I was at, I came to CVS Health, and so there was a long waiting list and never enough access. This is in the Boston market, and so we couldn't build enough primary care, and we couldn't build it fast enough, and that was the approach for that particular health system. And I would say coming out of it, that isn't the business that a hospital should be in, and they know it. More importantly, the way we look at it is we partner with health systems. So we have over 70 health system affiliates. And I think you've got to look at patients in 2 ways. One, there are patients that are already linked in traditional healthcare. And so we do everything possible to make sure we're connecting their healthcare and we're part of the care team. So we do clinical programs together. Hypertensive patient, instead of going downtown to the hospital for their ongoing monitor, they can come to MinuteClinic for that. The primary care provider or cardiologist is writing the treatment plan. We can take a look at it, the nurse practitioner, and we can be on the same page with that patient, delivering the same message in a consistent way. So those clinical partnerships and those partnerships with health systems for patients that already receive care there or diagnostics or whatever, we think is the right way to go. On the other side of it, there's a lot of patients, and we wholeheartedly believe in linking patients back to whoever they consider their main care provider. We ask them when they come in, And if they consent, we send the end of visit summary to that provider so that there's consistency and continuity. We believe that's really important.
Can you share data with them though? I mean, isn't this another way that data gets separated in different systems? If you're not going to the primary care or outpatient clinics of your health system, now your data is in whatever you guys use and the rest of data is in Epic.
They have full access to the EHR.
Yeah.
So we're on Epic and then through the HIE, SureScripts, et cetera. And then we even fax if need be.
Even everybody
Believe it or
faxes.
not. Whatever you have to do.
I saw an article a couple weeks ago that the NHS has banned the purchase of fax machines for all eternity now. They will no longer allow purchasing of fax machines in the UK system, which I think is hilarious. Good
So
luck.
the other side of the conversation are patients that don't have a care provider that they rely on. And so they come to MinuteClinic and they keep coming back. So we
Yeah.
make over 2.5 million referrals a year to primary care providers. 50% of our patients that come in do not have a PCP. So we try to get them linked into the medical establishment in some way. But there are plenty of patients that keep coming back to MinuteClinic. And so we need to have relationships with health systems and local healthcare providers to get these patients the care they need when they need physician level care, we're an NPPA model, or when they need diagnostics or specialty care. So from a MinuteClinic perspective and from a CVS Health perspective, we see the hospitals as, and the large physician groups as strategic partners. Obviously, some of the other things we talked about in regards to the economics of that relationship, especially through different health plans and relationships you have with the health plans, certainly could be another avenue for thinking about what those relationships could look like.
So what about that whole connectivity? You talk about connectivity back to the health systems that you guys are actively working on. And I think historically, and you can probably correct me, you guys have been more of an urgent care type of model or a sort of on the fly type of model. Now there's people coming back because they like their experience, but you've actively worked to develop these connectivities. How can y'all figure out how to link people for full aggregation of their health, experience? Because obviously a lot of the times when patients are coming to you, they're going to need a lot more than you can particularly provide. So how do you really think about them holistically? I know you guys have really theoretically built this into your model. Can you really do that? Can you really build in, thinking about cardiology and thinking about behavioral health and thinking about all of the different things that are likely to present so you can get people all the stuff they need into the right place?
I think so. So I think, for us, we even start with more fundamental, like bottom of the pyramid Maslow stuff. It's, can you
Right.
get housing and food, and can you get around? But I think there's two pieces to the question. So can you build tools that aggregate a full set of insights into a member? I think absolutely. Can you build tools that allow you to start to draw data from a variety of different points into a common ecosystem? Yes. And so for example, with us, we are drawing from HIE ADT feeds from Epic and a variety of other EHRs, and also from public social services databases into a single place. I think that is doable stuff. The flip of it is that the barriers to being able to aggregate information and making it useful are absolutely massive. And so, whether it is the challenges around regulatory barriers to access to substance use information, or whether it is the just structural challenges of integrating with every single one of the 72,000 different instances of Epic. I mean, these are very real technical challenges that I do not think get solved quickly. And there's a reason that I think larger organizations, frankly, have been more successful than very early stage companies in building through those walls. There is no silver bullet answer to interoperability, in my opinion, because it's not a question of how the tools are designed, it's a question of how they're implemented in very, very traditional legacy health tech.
What about you, Jenny? How do you guys really ensure that people get a full healthcare sort of picture taken of them?
Well, we are better, I think, at sending information out to our Epic partners. And we, like many people are talking about here, we partner with health systems, and we're happy to work with health systems because we don't do everything that they do. So we've gotten very good at referring into Epic-based Epic EMR health systems. Apparently at UCSF, we now refer better than their own faculty do. Because we have engineers, right? Because we're a tech company and we've got people working on this. So I mean, just because it's hard. So I think we're pretty good at that. whether you get all the information, I was always a huge fan of the blue button concept, and I know that's being kicked around in another iteration now, but I mean, patients should own their data, right, in one place, whether it's HealthKit or Blue Button or something.
Yeah,
And
I should be taller,
yeah.
It's not going to happen either.
Exactly, right. But you know, whether we're going to solve that problem, probably not. But we work very hard for the interoperability that's important to our patients, which is getting the records so they can have the appointment, and often making the appointment for them.
But are the physicians in your system trained to really, you know, look at the behavioral health aspects, to look at, you know, all of the different things that might not be so obvious in a primary care type of setting? Are they really equipped to know when they should refer versus keep?
Oh, well, behavioral health, since you mentioned it, Lisa, is probably the number 2 diagnosis amongst medical patients, mild to moderate anxiety, depression, right? So we are largely treating that ourselves. We're not referring that out because you can't get an appointment. So we're always managing in every market, can I send out? Is there someone? You know, how long is the appointment? Can I do it myself? What does the person need? We do group visits in our office to reduce anxiety and depression. So we're sort of always just saying, okay, what's at the top of our license? Which is different than saying, oh, we can't do that. Call the psychiatrist. Good luck, because there isn't
no
one.
kidding. No kidding. What about you guys? How on the pediatric front? Because
Yeah.
I mean, most kids, right? They're healthy. They don't need that much stuff. But then there's the ones that really do. How do you make sure that, you know, those kids are getting tended to?
So I think, you know, like Iyah said, I mean, we've done some integrations with Epic and through Fire and all. Is that where we're focused? Is that the expertise in trying to solve that problem today? No. I think what we're looking at is making sure, because you can aggregate all this information, you can collect it, and the technology's there. But how do you ensure that, and as we focus today on the Medicaid population, how are you making sure this underserved population knows how to access care? Because that's a real issue. And so it's not just getting all the data to drive outcomes, which we feel like we have a great advantage because we're getting the daily activity from school nurses where they are, because that's where we are, but making sure the average child gets the care they need on a preventative and care management side. And so the average parent, a Medicaid parent, not being sure how to access that care, one of the biggest asks we get from our payer partners is, can you help make sure all of our members know how to access care and the benefits that they have, so that they know that they have transportation, that they know the different social determinants options that they have to treat those issues, how to get care management around asthma, I mean the care management of education around asthma and the such. And so that's where we're focused, because there's a lot smarter people going to figure out the technical side, and I think there's noble, but there's a lot of barriers there. We look at it from an approach of making sure these kids have the care they need, because driving the preventative, the front end care, and making sure they're accessing it properly is going to drive better outcomes in the future.
So where does it break down? What doesn't work? Where does this disaggregation problem become a real problem versus a plus? Oh, nice looking away, Tony. You looked away right now.
Oh, is that for me now? Yeah, I was going to let someone else answer that hard question first.
No, I'm coming for you.
Yeah, so where does it become a plus?
Where does it break down?
Where does it break down?
Connectivity.
Sure. I think when
not
you
work?
get, I mean, listen, it's not good siloing the information. It never is. I mean, and so, and I'm going to go back to solving that problem with all the different iterations of EHRs in this world. Again, I don't know the answer to that today. But the one thing I do know is that is in the pediatric market, at least, is we know where these kids are. If there's an aggregated population there. So you talk about disaggregation, that's not true in pediatrics because they're all in the same place. Now, how you can get that information and contain that information, that can be a challenge. But if you give the opportunity for the parent to have all this information at their fingertips on a platform, immunization records. I mean, simple things. I mean, as simple as that. My wife this summer said, oh my gosh, we have to have immunization records for our kids to go to camp. Now, this is not this is a first world problem, don't get me wrong. But at 10 o'clock at night when she's yelling at me because she doesn't have them and it has to be done tomorrow morning, only because I have access to the state registry, I can call one of my doctors, say, can you get us why can't every parent have that record? Why shouldn't every parent have a record of their immunizations and what their kids need? Why shouldn't every parent have access to telehealth to make sure, at the middle of the night, to make sure they can access the care they need to? Why shouldn't every child at school have access to the basic preventative care and education around nutrition and all the different things that are simply easy to do if we connect it? And so that's the more important question for me when it comes to pediatrics, and making sure they have access to it.
So what about the rest of you guys? Where does it break down? What is the flaw in the separated model?
I mean, I think it breaks down when you put the patient in the middle. So when the patient comes in, they've been in, this is their third visit, their cholesterol is high, we've tried to get them back to their provider, and you're asking them, well, and they went back to their provider and something happened, and then they came back and they're still not on the statin or whatever. Like, I think that is the problem that we have when a patient comes in and you're trying to help them with the next best, whatever it is that they need, and there's a disconnect between what they've been instructed to do or what they're doing. It's not about the patient trying to broker that, it's about the care providers trying to have that conversation in the best interest of the patient. And it's not always data. Data is just one piece of it.
Any other thoughts from other folks?
Oh, go ahead. No, you go. I was just going to say quickly that, fully integrated models obviously shouldn't have this problem, right? Mm-hmm. But they do, because, and one of the challenges that I think it's not so much disaggregation as a lack of commitment and funding to primary care. I mean, I think it's just primary care is just low man on the totem pole, right, in the giant scheme of American healthcare. And so even at a place like Kaiser, the money goes, maybe not to the best primary care. And so I think that's why we're all kind of here. We've grown up out of this need to make it better. But it's not so much about just putting it all together. I mean, that's Medicare for all, essentially. Would that improve that? Maybe, but not necessarily.
It might improve that, but we'd probably all be
Have something else.
broke, right? So, you wanted to add something, Iyah?
Can, or you can move on, either way.
Go ahead, you add something.
You sure?
You go right ahead.
All right. So I think two other things that I would add. One, I think the operational tactics of this are also so important. So we talk a lot about the data liberation and what have you, but we actually don't have shared care plans, the things that matter. So we have a member, for example, currently, who I will fudge the details a little bit for her privacy, but suffice it to say we call her by member double-digit number because she's in the ED that many times a month. And we get ED pings, right? We're plugged into the HIE. We get a ping when she shows up and she registers. But she doesn't actually have anything quote unquote wrong with her. And so even though we're deploying a team immediately and we're at the ED within 30 minutes, she's often gone by the time we get there because she's left back out to the streets where she lives. And so the notion that there is not a common plan across the 7 different hospitals in Brooklyn that she frequents on a day-by-day basis to be able to say, hey, there's somebody responsible for this person, have a conversation. And the fact that until she gives permission to each of those 7 hospitals that she can talk with us, that they can talk with us about her, that they pretend to not know her, even though we have the data that says that she is there, is a fundamental disconnect in all of this fragmentation. And some of that's policy, some of that's culture. The other is that we're not talking at all about all of the other systems that are fragmented. So when you start to layer in housing and food supports, and you think about all of the public benefits that folks who are subsidized in some form access, each of which are siloed from each other, let alone siloed from us, it's easier for us to do first-party data collection. And by the way, more often than not, their data are wrong. And so nobody's actually asked the question in an empathic way and listened to the answer to understand what somebody actually needs. They just have an 180-item form that they've gone through and checked off. And so I think there's both a liberation issue, but there's also just a conversational issue, and we have to rethink how we ask these questions.
And I think one thing to add on that, because I think what population you're talking about is really important too, because they're not all the same. We got to stop treating them all the same.
Yeah.
You talk about data. When I said what we see in the partnerships with a lot of the large Medicaid plans in the states we work in, is they don't even have the data, nor do the PCPs have the data to manage the population that they are asked to manage. And so they come to us and say, can we, because you're in the schools, can we partner with you to make sure this population gets managed properly and we can go to where they are because we can't find them. And so so I think the conversation around primary care and all of healthcare, it starts first with what population are we talking about? Because my challenge is, as a commercial payer, commercial insurance, and where I live and the pediatricians across the street that my wife can walk to with the kids is a much different story than the Medicaid family living where there's one pediatrician in a 10-mile radius. And actually the closest place to get health care is the emergency room down the street. And we ask them, say, why are you using that as your front door? Well, because that's the only option I have.
Because I can get there.
We can get there, yeah.
So, I think CareDocs and CityBlock are primarily sort of business to business enterprise sale type programs, but CVS and One Medical are primarily, at least until recently, have been direct to consumer sort of enterprises. How do you build a consumer brand in this business to actually attract patients? Because for the most part, building a consumer brand in healthcare has been largely crap, right? I mean, it doesn't work very well.
Yeah.
So what have you guys done that's made it work? Or what have you not done that you wish you'd done?
Well, it is our goal to be the most loved health brand in healthcare.
Is that like the most loved cable company?
Yes. even better.
No offense to Michael.
Yes. Well, a little bit of a plug. So our One Medical members, we have a 90% net promoter score. So that is basically unheard of in healthcare, right?
Yeah.
So people, I was talking with somebody who's tried One Medical a couple times. We were sitting down for lunch and took a few times, but then they found the love. So I think, we're doing something for people because we care about them, we listen to them, we provide what they want when they want it. So our marketing has largely been word of mouth on the consumer side, and then what happened with us, we're now about 50% enterprise and 50% direct to consumer, because the consumers went to their employers and said, you've got to buy this benefit for me. Mm-hmm. So now employers, we have something like 3,500 employer clients, including some of the biggest names in the country, a lot of tech companies. That are not out to get us, as best I can tell, Lisa. So I think doing what people want, and yes, I know the bar is very low for being a loved brand in healthcare, but I think even moving in that direction really gets people's attention. And we spend on advertising, but really it's just listening to the patients and responding to them and saying, we're here, we're open for business, we'll help you.
So, being a former marketing and communications person, what I hear
please.
is we don't know how to build a consumer brand. What I hear is that you haven't done the traditional things that people do to build a big consumer brand, which is investing a lot of money. Maybe it's expensive.
Yes,
Not that you haven't raised a lot of money, because I know you have.
Yes, right.
But,
and some of that money is going for branding.
yeah. Because I think it's very different. If you think about how consumer products brand themselves, they invest tens of millions of dollars in that. But you guys have managed to grow without that. So that's interesting.
Yeah, we're lucky, and we're a startup, and we're still private, right? So we don't have that much money. But look at Kaiser's built back to Kaiser, but they've built an amazing brand, and people that are in Kaiser markets they spend a ton of money on advertising, right? So it can be done.
But they started as an enterprise model, right? So they
because
had
the
that
payer
going
side
for
of
them.
it, yes.
Okay.
And it is One Medical selling a membership to an enterprise customer is a bit unusual. Mm-hmm. So they buy memberships like they'd buy memberships to Equinox. But it's so important. In many cases, it's the number one most satisfying benefit that employers offer. So I think you're going to see a shift. What's important to
best
people.
Cable company. I don't know.
Yeah, I know.
What about for CVS? You guys have.
It's a little bit different.
Yeah.
So, I see.
You kind of have a consumer brand already.
MinuteClinic is a small startup in a large organization,
Right.
and so things that helped MinuteClinic, which you guys probably haven't been tracking, but of course I did. We changed our name of the organization right after. So first of all, MinuteClinic was acquired in 2006, and then a few things. So one, I don't remember the exact year, I think it was 2014, they took tobacco out of the stores. So that was a real big kind of halo in regards to really having a commitment to delivering healthcare. We also changed our name to CVS Health instead of CVS Pharmacy in 2015. I'd say some of the other things is our scale. We have 1,100.
You guys already had a big consumer brand to leverage.
Well, we bought MinuteClinic with 230 clinics, and now we have 1,100. So we have scale and national footprint. But I'd say the other thing goes back to a little bit of what Jenni was saying. We just do the right thing and stick to our value propositions, which are convenient. So 50% of our patients are seen after hours or on weekends. Accessible. More than 60% of the population is within 10 miles of a MinuteClinic. High quality on multiple levels, including our NPS, not as high, but at 86. And HEDIS measures at the top of the chart, et cetera. And then affordable. Transparency of our prices and keeping our prices at a price point even for folks that have either self-pay or folks that have high deductibles. And so just sticking with those value props. We've treated over 43 million patients. So I think that's what's gotten us our brand, and I would say the one way I know that our brand is out there is we get calls a lot in our call center from people saying, I was at a MinuteClinic, and typically it could be a compliment, but it's typically a complaint. And then we get into it, and it's like, no, that wasn't a MinuteClinic. That is a whatever clinic down the road. So people use the name MinuteClinic as a generic
Like
walk-in
Kleenex.
clinic. Yeah.
Yeah. So do you all employ your clinicians? They're all your people? Yeah. Do you?
They are contract workers, so they're seasonal for us because we ramp up and down depending
Okay.
on the services we're providing.
So for the other three, why do, whatever it is, clinicians, nurses, physicians, whatever they are, why do they want to work for you and not for, Dignity, Ascension, Kaiser, whatever? Why do they come work for you instead? I know people laugh. Don't laugh. That's not funny. Why do they want to? Why do they want to come to you instead?
I mean, I can speak for us, and actually, in some ways, it gets a little bit back to the branding question, although it takes a very different flavor for us. I get asked all the time when we're having conversations with health plans whether I'm worried about workforce, and I have to hold myself back from laughing because our phones are ringing off the hook from providers who want to work in an environment where they're not held to 12-minute visits, where they are able to actually have a real conversation with a member and do the right thing. They don't have to think about how quickly they bill. They get to be surrounded by a care team that meets all of their needs in a seamless way. They get to work in a technology suite that our chief medical officer works in every day and is built to delight them. There's not, frankly, much to dislike about it. It's a startup and it's messy and bumpy and all those things, and we sort of have a unique group of people in this early stage. We're a year in of folks who like that mess. But honestly, the same holds in others. If you talk to Caremore, Chenmed, Oak Street, you get the same answer from folks who are working in fully capped environments. What's interesting, I would say, is you also get it to an extent at a Kaiser. You get it at some of the fully capitated groups, although in a very different way. And I think the pressures even that those organizations feel from their own internal, fully integrated specialty and hospital partners, I think are very interesting to acknowledge. Whereas when you're actually disintermediated the way that we are able to protect them in a way that I think is pretty interesting. And so people get to do the right thing all day, which is pretty special.
You want to say something, Jenny?
Sure. I mean, I was shocked when I got to One Medical and I learned that when you show up for your appointment, the doctor has 2 minutes to go out and get you. And there dings on their computer if they don't.
Wow.
I thought,
What happens if
I
they
came
don't
from
show up in 2
Stanford,
minutes?
Where,
It's
can you imagine if they
Is there
were
an
in 2
electric
minutes?
shock or something if they don't show up?
I was like, no, that 2 minutes, we're just getting started. So
They miss one round of golf? if
Yes,
they-
right. No, I wouldn't say that. And then they clean the room. So these is very different. They're not wearing a lab coat. They're introducing themselves by their first name. So it's not for everybody. So I think similar, it's for people who are passionate about the work that they do, that they're really committed to the patient. They don't want an RVU-based reimbursement. They're salaried. And we give them complete focus on taking care of the patient and developing a relationship. Lots of hugs at the clinic. When you go in, if you do visit our clinics, people are hugging and everybody knows each other's name. So it's like cheers, but it's medical. So I think it's just, it self-selects, much like City Block, right? So you're going to find people who are passionate about it, and a lot of people work there for exactly that reason.
Can I just double click actually on one thing you said, which is subtle but really important, which is how they're compensated? We salary as well. I actually think it matters a lot. I mean, just salarying people and taking their compensation away from how they perform when you're in a clinical service role matters a lot.
Yeah, they're paid like the engineers. There's
Exactly.
no difference.
Yeah.
So engineers
Well,
are
there's
salaried.
definitely a difference.
Right. Well, there's a difference between the people.
Yeah.
Yeah, but some
No,
people.
I'm kidding. I agree.
But some people believe, and maybe they're right and maybe they're wrong. I don't know. But some people believe if you tie performance to compensation, then you get better outcomes. So you're sending them a different message.
I'm really old, and I've seen that tried many times in my life, and I don't believe it at all.
Not so much.
No. Pay
Until-
for performance for doctors. I mean, I don't know how many doctors here believe in pay for performance.
Until we know how to measure it. I don't think we know how to measure it.
Yeah, it hardly works on management people. How's it going to work on doctors?
Fair enough. What about for
Sorry.
you?
So we have an NPPA model, and what we offer is they run their practice. So it's a single provider model, and they run their local practice. And so that autonomy and ability to take care of diverse patient population is something that's really attractive to the nurse practitioner PA group. I'd say the other thing is we are an innovative company, so there's constant change and constant, whether it be digital tools, whether it be scope of practice, whether it be how we configure the physical space. So I think people like that. And then the third thing I'd say is we have a nursing structure. So we have a CNPO in addition to a CMO, just different than a lot of the retail health offerings. And so we have a whole virtual community that I think is stronger than being physically located together. That creates a level of support, whether it be academically, whether it be precepting, whether it be curbside consults in regards to a particular patient. So I think that's our secret. And then I'd say we are so committed to the nursing. We actually, I probably shouldn't say, I'm not sure I can say this, but I will. We actually are going to, working toward magnet status for the CVS MinuteClinics.
Very cool.
We'll be the first retail organization to do that, but we haven't done it yet, so that's probably why I shouldn't be saying it, but we are certainly trying.
So I'm going to leave you out of this question because you've already merged with a payer. But Optum, Humana, these guys are buying up clinics left and right. They're your competition in a lot of ways, but they're also the payers that pay you. Is that awkward? Is that getting awkward? Is it getting weird? Is it? I mean, clearly, it's already happened here, in a very fundamental way, or it's on its way to happening anyway. This, the big payers want to be fully integrated health systems, or at least without the walls of the hospital. So, does it worry you?
No, not for us. I mean, I look at where we are. I mean, our whole strategy is around going to where the patient is, where the kids are, where they're aggregated. It's partnering and leveraging schools. It goes back to the question about the consumer, because we actually do have a B2C, because we're actually engaging the individual families to become our members, partner with us. And one of the things, the advantages we feel like we have over anybody is that we are leveraging the trust that a parent has in their school. And so typically, I have kids, I mean, if it comes home from the school, in a lot of cases, you're going to have a higher level of trust that's been vetted. There's a partnership, so then we engage with them at that level.
Are you saying people don't trust the payers?
But I think, so you look at, you talk about Optum or these other large companies. No, because at the end of the day, if you're looking at healthcare and consumer and we have to engage. I think one of us said up there is when we put the patient between the doctor and the care, you have to make this about the patient. So if you empower the patient and you engage them in that relationship, I mean, how often do we get stuff from our payers, a list of care management things and that they would like you to do, and it's written out, and they say, and what do you do with it? I know what I do. I throw it in the trash and throw it away. Because it's not, they haven't engaged me. I have no relationship with them. So we are creating a relationship through the school with the family and their child. And so because of that, we're not, the other Optums or these large companies don't scare us. I mean, we view that they can be partners. We have contracts with them, with United and all of the major payers, but we're not afraid of them. They don't scare us.
So are they going to cut you guys out of their networks?
I don't think so. I mean, I'll say this, not when we are servicing their members in their schools and we're driving preventative care. And what we've seen, patients like it, parents like it, families like it. And so I don't think it's good business for them to start going against what their members want.
There's tensions that are going to emerge. We're going to see a lot more consolidation. But I mean, look at the history of hospitals buying docs. They've not integrated successfully. I mean, we've seen this movie play before. I was catching up on my podcasts flying out here yesterday, and I hadn't listened to one of my favorite people on Trevor and Steve's podcast, A.G. Breitenstein. And Trevor Price and Steve Krause asked A.G. why in the world hasn't Optum integrated all of its practices, and she just laughed. She said, well, that's a 5-year change management project. And I think, and that's if you're being optimistic. I think the notion that the world is going to change with all respect because plans buy assets is I just don't believe it. I think that we are far from understanding what it means to fundamentally rebuild care models, so I'm just not worried about it.
So you're not afraid of Optum and Humana and those guys, but what about Amazon, Google, and Apple? Are they coming for you? Anybody?
One of them is our business partner. We do all their on-site clinics. Maybe I won't mention, but you might guess. And we do all their on-site clinics, and they buy memberships for all their employees off-site in all of our markets. So I don't think so. I mean, I don't
Because they're
know.
building clinics, right?
We should ask Missy, though.
Yeah.
Missy's here. She tell her.
She left.
Oh, she left.
She saw the
Okay.
question coming.
Okay. There she is. So let's ask Missy that question. But I mean, in general, I agree with the comments that have been made. Is that we can partner with payers, we can partner with enterprise customers, we can partner with technology companies. We're really just interested in providing primary care, and most of those companies are not really that interested in that precisely. So we're going to get really good at that, and then we'll partner with anybody who wants to work with us.
Do you want to add something, Iyah?
You can come for pieces. I mean, I came out of one of them. So City Walk came out of Alphabet Sidewalk Labs. So some sort of interesting insights into it. But I think they're going to come for pieces of it. I mean, I think your point about brand. None of us, I would argue, know how to build brand in healthcare. And when Amazon decides,
CVS probably does.
Yeah, none of the three of us know how to build brand. And when when Amazon adds, Prime telehealth for $1, like it's going to change the way that we all access health services. I fundamentally believe that because they have consumer trust already. I don't think that they're going to build bricks and mortar all over the country because, by the way, we need a lot less bricks and mortar. And so there's a different conversation to be had there.
Interesting. So, last question. Look out 3 to 5 years. What services do you provide that you don't provide now? Or is it the same? Sharon?
So we're moving in the direction of I guess two things. One, what are our patients coming in for? And looking at modifying our services to be able to accommodate that. And so I'd say that's one piece. And then the other is how do we leverage what we've built? Something that's in the community, something that's easy to access, and something that's impactful, both from a cost perspective and from a health outcomes perspective. So we continue to, I'd say, try to meet our patients and then also leverage our nurse practitioners and PAs to practice at the top of their license. So I don't think we're going to move away from being the sore throat place. We have treated over 60,000 patients around chronic disease, treatment and management, diagnosis, treatment, and management. And so I think we will continue to leverage that to provide services that our patients need. And then I think the other thing is it's going to be critical to integrate with different providers, whether it be around mental health, whether it be around specialty care. And so I'd say we are going to have much stronger relationships there than we have now. I don't think it's going to be 5 years, though. It's going to be 2 years.
Okay.
I don't know, all of it. I mean, we're so early in our journey, honestly, Lisa. I think there's so much that we will build in the next years. I think probably the most significant change as it impacts what we do is that we are going to, those of us who take risk, meaningful downside risk, are going to fundamentally pay social services organizations very differently than they are paid today. So we're going to build networks and we're going to drive incentives to all of the community-based organizations that are fundamentally going to end up operating like networks. And I'm not sure if that's a good thing or not, frankly, because it means healthcare is defining the standards for what it means to provide good social services, but I think it's going to happen anyway.
Okay. Jen?
We'll continue to innovate in behavioral health, women's health, sports medicine. I think the interesting thing is most of our services are covered by insurance. We're billing insurance. And how many things will we provide you that are not covered by insurance because you want them? And they're healthcare related and you want a clinician to organize them for you.
Like Botox shots and things like that.
I mean, I don't know that Botox would be the first thing, but it might be for me.
If you want to make money.
No, but I think things that you see, there's some startups that are very specifically in the non-covered benefits space. I can think of HIMSS as one, which is a good, interesting model for erectile dysfunction drugs and hair loss drugs, right? Those, should that be a completely separate thing? I mean, our doctors would prescribe those things too, of course. But how do we play in that space? Or is it dentistry? I mean, because you like our One Medical office so much, should you come in and have your teeth cleaned too? Because that'd be easy, and we have the physical space. So I think we'll innovate in the kind of broader category of things that are important to people, not to insurance companies necessarily.
Okay. Tony?
So I think in 3 years we'll be in over 25% of the public schools in this country with our platform in enabling and coordinating care, facilitating care in traditional and non-traditional manners for kids. And ultimately they will be able to reach into the entire family and do the same for the family, because if a parent's going to trust you with their kids, then why couldn't they also have the same access to the care that they need? And I think the question will be asked is why should, for pediatrics at least, why should preventative, non-acute, and care management not be done right where the kids are? Where you don't need any more brick and mortars, you can use technology, and you can literally go and make sure kids get the care they need, which will then have benefits generationally because you're training them how to access care, how to take care of themselves. And that's really where you're going to see change, is as soon as you allow people to own their health care and to empower them to make decisions and to access the care that they need for themselves.
Okay. Rob, are you out there? Do you want us to open it up to the audience? So any questions from the audience? Folks have time for a minute? Gentleman at the end there.
Yeah, my name's Iyah Romm. I'm from Allied Physicians Group, and we're a primary care pediatric group with 150 providers, all pediatricians. I sat here listening, and I thank you for your answers today. What I didn't hear was, I think we heard a little bit from Jenni about physicians and the importance of physicians in here. Generally, with the exception of One Medical, the organizations that sit up here are not big fans within the physician community, because the independent physician community feels like as if you're taking away their business. How do you balance that between independent physicians who the continuum need to be able to support healthcare, who are providing high quality care, and the businesses that you built and are important to the continuum of healthcare right now? What's the balancing act there?
Anyone want to grab that?
I can start. I think there are maybe a macro comment and then how I think about it specifically. So the macro comment, and I don't, to be clear, believe that this is the right thing, but I think that the independent physician, as we know it, is increasingly receding, and that's going to only accelerate. And that is, again, not necessarily a good thing. We actually are pushing back pretty hard in our structure. So, back to the notion of what is primary care at the top. We actually, for about 60% of our population, we do not serve as the assigned primary care provider. So we wrap around very intensively and in effect serve as what one would consider a clinically enabled MSO model that enables a PCP to maintain a relationship, maintain independence, and bolts on all of those services that one might need: after hours care, weekend coverage, intensive palliative care, behavioral health services, and the like. And so, though we employ primary care providers who operate in a different mode, they really are an augmentation to our care team around PCPs. I think that is the only, frankly, hope of maintaining the notion of supporting, because most independent primary care providers are not going to be able to achieve the scale necessary to invest in the kind of capabilities underlying significant population health. And so figuring out how we find partnerships that build those services and partner effectively around a population is really important. We've done it because, frankly, it's less of a sort of political statement of what the market should look like, but I believe that we should not disrupt trusting relationships. And so where our members, where people who are assigned to us for risk, have a relationship with a PCP, we should honor that and embrace it as opposed to leaning away from it. And too many of these models make the wrong person make a different choice, which is fundamentally asking the most vulnerable person, who's the patient or the member, to go to a different place for better care, and I don't think we should be doing that.
Anybody want to add anything?
Well, I think I think one is the conversation we have with the local pediatricians is, we are seeing the population that they're not seeing. And we know that because we're working with the payers to get the kids who have not seen a PCP in over a year. And so we're not, and then if you look at preventative care is done all over in several different avenues today. Ultimately, we think as it goes more to a value base and where large pediatrician groups, talk about pediatrics, are at risk, and that we then become their greatest adversary, greatest partner. That we can work together, because as I specifically always state, is our goal is not to be the provider at the end of the day. Our goal is to facilitate and coordinate the care in traditional and non-traditional manners, meaning it can be at a school site or enable that care and making sure that individual is connected to their medical home and working with local pediatric groups to make sure that kids are getting the care, because today, for the Medicaid population, a large percentage is not.
Yeah. One more question maybe, anybody?
So a lot of the conversation episodic type of interaction that you have with your clients, your patients, your members. But most of the health happens at home. How do you actually integrate that into your care continuum, in your conversation?
Anyone want to grab that?
And I'm
Sharon?
Steve Sturgeon, by the way. David.
Sharon or Jenny or?
I mean, I would say, so it's limited, I'll be honest. I think we have access to the EHR. We get incoming just as much as outgoing. We obviously do a full history at the intake. And I'd say that is something that we look to improve as we develop our partnership with Aetna, look to have access to a little more data, and more importantly, they have a whole network of providers, social workers that work with their members, and so we see it as a limitation and are excited about bringing that aspect into the care that we provide now, but it is a limitation.
Yeah, I would just add that it's not really what you were asking, but virtually, we are in people's homes. So they're, calling us about they're going out of town and they don't have their prescription at 11 o'clock at night. What do? And they're doing that at home, or they're doing a video visit with us. So by virtue of our technology, we're wherever they want. I mean, we're on the road, we're at their house.
It's still episodic.
Yeah.
The fact that they have to reach through to you, it's shortening the time of the episode.
Well, it's episodic, but we're looking at their record. So, this is our patient. They've joined us. They have a membership. So they're saying, I don't know what I do about this thing. So it doesn't feel as episodic to our patients as you're describing.
But I mean, perhaps what I mean is that how do you integrate technologies like continuous glucose monitoring into your?
Oh, we'd love to do that. Just
So
hasn't happened yet.
That's more than
Yeah.
continual care.
Yeah, but that will come. I mean, I think we're all ready. I just don't think the technology's there in any kind of easy, inexpensive way to do that. But eventually, we'll all be doing that, I believe.
So,
Don't you think?
yeah.
Huh?
Sorry?
We talk about continual monitoring at home and getting in the house, and Missy just ran away again. She came back.
Yeah. So I have a question for the audience. How many people here have used one of these companies to get care?
Whoa.
A lot.
That's a lot.
I'm not surprised, actually. I expected that. I think it's
Counting your
becoming.
prescription at CVS?
I don't think.
No.
I go two
Wow.
hands, and if it's
Yeah, I've used CVS,
Wow.
Minute
That's
Clinic,
a lot.
and
That's
One
a
Medical.
high.
So anyways, I think it's really interesting because I think the delivery of care on the front end has really changed a lot. And I think it's worth noting. I left that question to the end on purpose, because I think if you asked it at the beginning, it would have changed the conversation a bit. But I think it really is changing. And I think a lot of the work that's being done out there to make care more accessible and more friendly is really important. So it's delighted to have you guys here. Thank you so much for participating today. Thank you all for coming and watching us eat up here. We are delighted to have had you. Thanks again.